Welcome and thank you for tuning into A Sound Constitution at CHLY 101.7 FM with Cassandra, Sam, Karla, Kelly, Max, and Harris. We're fourth-year Bachelor of Science in Nursing students at Vancouver Island University in Nanaimo. We're working to demystify healthcare issues affecting our community, bringing you evidence-based information about our healthcare. This information is for education purposes only and does not replace the advice of your primary healthcare provider.
We would like to start our show by acknowledging that we are on the unceded territory of the Nanaimo people, with a broadcasting range that overlaps the Kuwatsan and the Sliaman territories. This acknowledgement is done with gratitude to the Nanaimo people and with the intention to increase awareness about truth and reconciliation processes and efforts on Vancouver Island. Additional information and resources surrounding Nanaimo history, reconciliation, protocol, and land acknowledgement can be found on our Facebook and YouTube pages.
Welcome to this week's episode of A Sound Constitution. My name is Karla, and I'm joined this week by my co-host, Max. Thanks for tuning in. In our last episode of the season, we are discussing a topic that is so important for people to consider for themselves and for their loved ones. It is an essential part of health literacy, yet many people can feel uncomfortable about discussing it. What do you do when you are living with an incurable chronic illness with perhaps some difficult symptoms, or you are nearing the moment of your death with a terminal illness and you need to consider a different approach to acute medical care? What options or degree of medical interventions are available for you to choose to receive, and how can you be most comfortable and supported at this time in your life? Well, today we are talking about palliative care, sometimes called hospice care, and the options and benefits that are available for people to choose from when they are in a hospital or a community setting. In this episode, we will listen to some engaging TED Talks from an emergency doctor about the importance of talking about dying, and later from two palliative nurses who answer common questions that people might have about the dying process. My co-host Max is going to review the physiology of death from a medical perspective and imagine what happens to the body as it shuts down. Our special guest today is a nurse who worked in palliative care for close to 25 years. She is going to share with us some of her insights into how nurses can best support patients and families in the dying process. At the very end of our show, we have a special treat. We will be listening to the advice and wisdom of 4 centenarians, each living over 100 years, who encourage us with suggestions for how we can live our best lives possible and what healthy habits have helped them to live as long as they have. Most people tend to shy away from thinking about death and dying. We are all living longer and healthier lives, enjoying the benefits of an advanced field of medical science filled with better drugs and better surgeries. Why should we care at all about the moment of death when there is so much life left in us? Well, we can't control if we die, but we can occupy death, in the words of Peter Saul, an emergency room doctor. In this next TED Talk, originally aired in March 2012, he asks us to think about the end of our lives and to question the modern model of slow intubated death in hospital. 2 big questions can help you start this tough conversation. Let's listen now.
Look, I had second thoughts really about whether I could talk about this to such a vital and alive audience as you guys. But then I remembered the quote from Gloria Steinem, which goes, "The truth will set you free, but first it will piss you off." So with that in mind, I'm going to set about trying to do those things here and talk about dying in the 21st century. Now, the first thing that will piss you off undoubtedly is that all of us are in fact going to die in the 21st century. There will be no exceptions to that. There are apparently about 1 in 8 of you who think you're immortal on surveys, but unfortunately this isn't going to happen. While I give this talk in the next 10 minutes, 100 million of my cells will die. And over the course of today, 2,000 of my brain cells will die and never come back. So you could argue that the dying process starts pretty early in the piece. Anyway, the second thing I want to say about dying in the 21st century, apart from it's going to happen to everybody, is it's shaping up to be a bit of a train wreck for most of us, unless we do something to try and reclaim this process from the rather inexorable trajectory that it's currently on. So there you go, that's the truth. No doubt that will piss you off, and now let's see whether we can set you free. I don't promise anything. Now, as you heard in the intro, I work in intensive care. And I think I've kind of lived through the heyday of intensive care. This has been a ride, man. This has been fantastic. We have machines that go ping. There's many of them up there. And we have some wizard technology, which I think has worked really well. And over the course of the time I've worked in intensive care, the death rate for males in Australia has halved. And intensive care has had something to do with that. Certainly a lot of the technologies that we use have got something to do with that. So we have had tremendous success. And we kind of got caught up in our own success quite a bit, and we started using expressions like life-saving. I really apologize to everybody for doing that, because obviously we don't. What we do is prolong people's lives and delay death and redirect death, but we can't, strictly speaking, save lives on any sort of permanent basis. And what's really happened over the period of time that I've been working in intensive care is that the people whose lives we started saving back in the 70s, 80s and 90s are now coming to die in the 21st century of diseases that we no longer have the answers to in quite the way we did then. So what's happening now is there's been a big shift in the way that people die, and most of what they're dying of now isn't as amenable to what we can do as what it used to be like when I was doing this in the 80s and 90s. So we kind of got a bit caught up with this, and we haven't really squared with you guys about what's really happening now, and it's about time we did. I kind of woke up to this a bit in the late 90s when I met this guy. This guy is called Jim Smith, and he looked like this. I was called down to the ward to see him. His is the little hand. I was called down the ward to see him by a respiratory physician. He said, look, there's a guy down here, he's got pneumonia, and he looks like he needs intensive care. His daughter's here, and she wants everything possible to be done, which is a familiar phrase to us. So I go down to the ward and see Jim, and his skin is translucent like this. You can see his bones through the skin. He's very, very thin. And he is indeed very, very sick with pneumonia. And he's too sick to talk to me. So I talk to his daughter, Kathleen, and I say to her, did you and Jim ever talk about what you would want done if he ended up in this kind of situation? And she looked at me and she said, no, of course not. I thought, okay, take this steady. And I got talking to her, and after a while she said to me, you know, we always thought there'd be time. Jim was 94. And I realized that something wasn't happening here. There wasn't this dialogue going on that I imagined was happening. So a group of us started doing survey work, and we looked at 4,500 nursing home residents in Newcastle, in the Newcastle area, and discovered that only 1 in 100 of them had a plan about what to do when their heart stopped beating. 1 in 100. And only 1 in 500 of them had a plan about what to do if they became seriously ill. And I realized, of course, this dialogue is definitely not occurring in the public at large. You know, I work in acute care. This is John Hunter Hospital. And I thought, surely we do better than that. So a colleague of mine from nursing called Lisa Shaw and I went through hundreds and hundreds of sets of notes in the medical records department looking at whether there was any sign at all that anybody had any conversation about what might happen to them if the treatment they were receiving was unsuccessful to the point that they would die. And we didn't find a single record of any preference about goals, treatments, or outcomes from any of the sets of notes initiated by a doctor or by a patient. So we started to realize that we had a problem. And the problem is more serious because of this. What we know is that obviously we are all going to die, but how we die is actually really important. Obviously not just to us, but also to how that features in the lives of all the people who live on afterwards. How we die lives on in the minds of everybody who survives us. And the stress created in families by dying is enormous. And in fact, you get 7 times as much stress by dying in intensive care as by dying just about anywhere else. So dying in intensive care is not your top option if you've got a choice. This is a quote from Dame Cicely Saunders, whom I met when I was a medical student. She founded the hospice movement. And she says, "You matter because you are, and you matter to the last moment of your life." And I firmly believe that that's the message that we have to carry forward. Thank you.
You've been listening to a March 2012 TED Talk by Dr. Peter Saul, who is a senior intensive care specialist in the adult and pediatric ICU at John Hunter Hospital and director of intensive care at Newcastle Private Hospital in Australia. Over the past 35 years, Peter Saul has been intimately involved in the dying process for over 4,000 patients. He is passionate about improving the ways we die. The need to discuss the possibility of our death and be prepared for choosing the right level of medical care shows clearly in the statistical data for Nanaimo provided by the BC CDC, a provincial online community health data website. Here it shows that currently almost 25% of the population in Nanaimo is 65 and older. This population demographic is expected to remain high and grow over the next decade. What this means for our listening audience is that we must support our aging population in Nanaimo and the surrounding area to find client-centered, family-friendly ways to support end-of-life care. One of the best resources for doing this is the Nanaimo Hospice Society. From their website, www.nanaimohospice.com, I was able to pull the following information. Nanaimo Hospice began in 1979 with Olivia Thomason, who developed an interest in starting a hospice service in Nanaimo following her husband's death from cancer. She was soon joined by Lynn Green, an RN who worked with the dying and also saw a strong need for hospice services. Their goal was to promote a model of care that emphasized emotional social caring for patients and families. Their dream was to build a hospice facility with beds where staff could promote and facilitate quality of life, family were welcome, and the patient could live out their last weeks or months in dignity or peace surrounded by people who cared for them. Nanaimo Community Hospice is part of an interdisciplinary hospice palliative care team of professionals and trained volunteers. Their team of staff and volunteers support the doctors, nurses, social workers, chaplain, home support services, dietitians, physiotherapies, etc. at the palliative care unit in NRGH and within the community. Did you know that 2021 is Nanaimo Hospice's 40th anniversary? Olivia Thomason was the founder of Mid-Island Hospice Society, later changed to the Nanaimo Community Hospice Society in 2006. Nanaimo Community Hospice launched a community outreach vehicle in 2019. They have direct contact with over 1,750 individuals and family members dealing with end-of-life issues. They presently have 150 client-based volunteers and 80 volunteers working at their thrift shop. Here's an interview with Anne, who has been volunteering for the Nanaimo Hospice Society since 2001. This interview originally aired on Nanaimo Shaw TV in September of 2013 and can be viewed on the Nanaimo Hospice website.
Surrounding the warm flicker of a candle, a small group gathers to comfort and support each other, discussing the array of emotions they're experiencing while grieving the loss of a loved one.
This is a safe and secure place for everyone to come and talk about their grief.
For Anne Judson, a volunteer and grief support facilitator at Nanaimo Hospice, providing a safe and confidential place to listen, to share, and to support someone's journey through grief is more than just a way to give back to her community.
Grief is a natural human emotion to a very profound sense of loss. And it's important that we all work through those emotions that are associated with grief to make us healthy individuals, to put us back on sort of the road of being a good, productive part of our community. So is everyone okay with everything that's said in this room stays in this room?
Anne has volunteered with Nanaimo Hospice since 2001. She donates her time both to the organization and to hospice clients by facilitating support groups, visiting clients at home, and supporting and mentoring staff and new volunteers, work that she considers very rewarding.
I don't think any of us could do this work without getting some payback ourselves and without feeling some reward. For me, it's seeing people come in on the first night of a grief group. They're scared, they're afraid, they don't want to be there, they're angry, they feel that it's really unfair that they've had to come to this place. And as they progress through the 8 weeks of our adult grief support program, you see the change in them. You also see them start to support each other.
Anne has had a very big impact on the organization as a whole. She's been here for a long time and she has a lot of wisdom and a lot of compassion, and so she is able to share all of that and help us all learn and grow.
How about if we look at this one? Okay.
With compassion and dignity, the staff and volunteers at Nanaimo Hospice offer emotional support, free programs, resources, and education to all members of the community when and where it is needed most.
It's really more a philosophy of care. We are here to provide support at end of life and for those who are grieving so that they can reintegrate into the community, that they can become more healthy participants in the community.
I think it's important to have a companion to be with, to just help them navigate through those waters, to reassure them that everything's going to be okay, that what they're experiencing is normal. And I think it provides a bit of a safety net for people.
Wow, those are some big words in there, aren't there?
Hospice provides excellent training that is well respected in the healthcare community, and anybody can do this job. We all grieve, we all will be there one day, and it's just nice to know that there are volunteers who can help make that process a little bit better, a little bit more comfortable, and a little bit more safe for people.
Thanks to the continued efforts of Anne and the many volunteers at Nanaimo Hospice, anyone who is experiencing grief has a place to find compassion and support. To find out more on the array of programs that are offered to the community, visit NanaimoHospice.com. In Nanaimo, I'm Jocelyn Matui.
Thank you to the Nanaimo Shaw TV, who originally aired this interview with Anne, a volunteer for the Nanaimo Hospice Society in September of 2013. We wish the Hospice Society continued success as they celebrate their 40th anniversary. Here to talk with us next is Max, my co-host, who would like to share some information about the dying process and some common questions that people may have at the end of their life.
Continuing this week's episode of A Sound Constitution here on CHLY, my name is Max, and I thank you for joining us today as we discuss palliative care and end-of-life processes. Nurses caring for patients nearing the end of life often face common questions from patients and their family members. Are they in pain? Why are they breathing like that? Do they need food? We're going to play a discussion from two hospice nurses addressing these common questions and describing what the end-of-life experience is like for palliative patients and their families, and explaining why nurses and healthcare professionals take the steps they do to treat the signs and symptoms of imminent death. Let's hear from Jennifer Kazmaier and Raman Bonwait, two registered nurses with Calicare Home Healthcare Services, speaking in a presentation by Heart House Hospice.
As nurses working in the community, we often are caring for families who want to help a loved one die with dignity at home. So the purpose of us speaking on this video today is to address some of those signs and symptoms of what dying really looks like, both physically and emotionally, so that family members are equipped to be able to care for their loved one and not feel that they need to rush them to the hospital at the last minute. We really get a lot of reward from doing what we do because palliative care is an incredible opportunity to make a difference in someone's life. It's something that can be so positive because you only get one shot at it, and you can make an incredible impact for the family member and for that person to make sure that it is a positive and potentially even beautiful and peaceful experience.
When your loved one is nearing the end of life, there's sort of two stages you may see within 1 to 2 weeks close to death, and then there's sort of imminent death. So within the 1 to 2 weeks, that's when you already have started to see some weight change. They may be losing quite a bit of weight. Changes in their skin color. They may be a bit more pale. Their skin may start to become cool and clammy. You may start seeing changes in their vital signs, so their blood pressure might fluctuate, their temperature might fluctuate as well, and along with their heart rate. So you might start to see swelling in their body, in their extremities, their arms, their legs, their feet. And you also may start to see in the earlier stages some confusion or hallucinations, more so I think at nighttime in the earlier stages, but that may also start to happen.
Another a symptom that you may see is weakness and decreased levels of energy. So they may spend more time resting, sitting. Their appetite may change, so they may not be wanting to eat the same way that they did for someone who always cooked and had, loved their meals. You may see that they don't have the same interest in food that they used to have. So that can be sort of the earlier stages.
The decrease in lack of appetite is something that you will likely see closer to the end of death. And it's really important to remember that you shouldn't feel guilty. They may just not be feeling up to eating. And sometimes, you can try something different at your loved one's in the hospital and they may not be up to eating the foods in the hospital. You can try and bring something from home, see if that might stimulate some of their taste buds and maybe get them to eat a little bit. But it's very important not to feel guilty about it, because they just may not have that appetite to eat.
Mm-hmm. What I often counsel our patients on is, if all you feel like eating is pina coladas, then go ahead and do that. Mm-hmm. It's all about comfort and what they want and their quality of life. So if their appetite has decreased, don't feel that you need to force them to eat food or fluids. Offer it to them, make it available to them, but don't feel that you're starving them or that that you're somehow contributing to this process, because this is normal for your appetite to decrease as the body just requires less energy as it's beginning to shut down and move towards the dying process. Anxiety and restlessness at the end of life is a normal symptom and change in behavior, which can be caused by physical symptoms as the body is beginning to shut down and change the processes. So it could be something related to change in the oxygen level in the brain, related to energy that the body's taking in, but it can also be things that mentally and spiritually a person needs to address and work through as well. So there are medications that are available, and when we're looking at medication use, it's something I like to say, we use these medications to address a physical symptom so that the spirit can rest.
Yeah, and sometimes pain can also be a cause of anxiety and restlessness, and that's something that you can just, again, address with pain medication and see how that's tolerated, and hopefully that will lead to a decrease in the anxiety. Sometimes the anxiety may just be with coping with death for them, knowing that their end of life is near. Everyone copes with it differently. Somebody may be ready and somebody may not be. So it's very important to sort of be involved in that process and understand what their thoughts are and what's happening.
I think the scariest symptom at the end of life for family members is the change in breathing. And often you will see pauses in breathing. It could become irregular. You can hear a change in the noise of breathing, which can kind of sound like a rattle. And physically that can be a buildup of secretions in the lungs. Often people say that this, we don't know for sure, I suppose, but that it's not uncomfortable for the patient and for the person experiencing it, but it can be disturbing for the family member who's there beside them and hearing these noises. So I think that's probably the most common reason that someone would call 911, and being aware that there will be breathing changes and changes in the sound as someone nears the end of life.
And it's likely that you'll also see some changes in their skin color. There's something that you would see, it's called mottling. So it's discoloration of the skin that may start sort of from the bottom up in different parts of the body. You may see it on the back if they're lying down or flat on the surface for a long period. So anytime that you do start to see some mottling, death usually occurs within about 24 hours of that time period.
Mm-hmm. their level of consciousness will often change quite significantly as well. So before, it does happen that someone is conscious right to the end and saying their last words, and then, like the movies, they close their eyes and they're gone. But more often, they're probably unconscious for a period of time before death actually occurs. So they won't be taking any food or fluids at all. Their breathing will be irregular. You'll probably see some mottling, changes in skin color. They'll be cool to touch. So at that point, it's important to do things like mouth care, keep their lips lubricated, manage any symptoms that they have. If they are agitated or unable to, or moving around in bed and seem uncomfortable, that's when you want to be giving them medications to manage those symptoms so that their physical body is not in any discomfort. But mostly it's the changing in breathing and level of consciousness that you always see.
You also likely see a decrease in the output, so there may not be any bowel movements happening or any urine being put out because they're not having much intake as well, so you'll see that effect. I think just being able to read and recognize facial expressions is very important, and a lot of times near the end of life, if they're no longer able to verbalize their pain, you'll see some facial changes. They'll be grimacing, moaning. Sometimes they may be reaching for certain body parts if there's pain specific to a certain area. So those are certain things you can pick up on to realize that pain may be a factor in what's happening at that moment.
That was Jennifer Kazmaier and Raman Bonwait, 2 registered nurses with CHLY Home Health Care Services, speaking in a presentation by Heart House Hospice. As we heard, nurses caring for patients at the end of life face many common questions from family members, and I hope this segment served to address some of those questions. Witnessing the end of life of a loved one can be a jarring experience for people, as the sounds produced during respiration as fluid and mucus collect in the lungs and respiratory tract are something most people will not have witnessed before. A type of gurgling noise is common, colloquially referred to as a death rattle. From what I personally have seen in practice, this is commonly managed with an anticholinergic medication called scopolamine, which helps to dry up these secretions and reduce the sounds heard. This may be done as much for the comfort of the surrounding family members as for the comfort of the patient. Patients may also experience an irregular pattern of breathing known as Cheyne-Stokes respiration, or chain stoking. This is a cyclical pattern of respiration where patients may breathe rapidly and superficially for a short period of time, then slow their respirations down to virtually nothing, in some cases stopping breathing entirely for a short time, before repeating the cycle and hyperventilating again. This cycle can be alarming to witness, but is an extremely common occurrence in end-of-life patients. When a person dies, certain physiological processes stop, and others begin. I'm going to talk a bit about what happens in the hours after a person's physical body dies. This information is compiled and adapted from articles by Omnicare Hospice and Chris Raymond at Very Well Health, medically reviewed by Dr. Isaac Opel. Just a reminder that the information presented here on A Sound Constitution is for educational purposes only and does not replace the advice of your primary healthcare provider. Additionally, some listeners may find this information upsetting, and we advise you to use your own discretion. Some people don't want to think about the changes in the body after death, whereas others do. Everyone's different, and it is a very personal thing. For those who wish to know, however, we are learning that the bodily changes leading up to death and after death aren't simply random decomposition. Our bodies are actually designed to shut down and die at some time in a programmed, predictable manner. There are 4 stages the body goes through following death, known as pallor mortis, algor mortis, rigor mortis, and livor mortis, and we're going to talk about each stage. Barring a severe traumatic injury, death is not an instantaneous on-off event, but rather a process. As respiratory and cardiac activity gradually slow and eventually stop, oxygen is no longer being carried throughout the body in the blood. The vital organs of the body can no longer function properly. The synthesis of adenosine triphosphate, or ATP, the body's great energy carrier which fuels cellular activity, is no longer possible. The person's body temperature will drop and their skin will appear pale or mottled. Their weakened circulatory system begins to lose the fight against gravity, and their blood will begin to pool. In a hospital setting, there are several criteria used to define death. These include the absence of a pulse, the absence of breathing, the absence of reflexes, and the failure of the pupils to constrict when exposed to bright light. The definition of brain death includes the absence of brainstem reflexes, the inability to breathe without a ventilator, and neurologic unresponsiveness. The diagnosis of brain death is used to declare a legal death, such as before an organ donation. After physical death is confirmed, the timeline of physical processes is as follows. At the moment of death, all of the body's muscles relax, a state called primary flaccidity. If you remember our episode on the musculoskeletal system, you'll know that muscles need energy to function, and this energy comes in the form of adenosine triphosphate, or ATP molecules. You might also remember that our muscle fibers contract due to the bonds formed between protein bands called myosin and actin. ATP energy is required to break these bonds and let the bands move away from each other, which lets the muscle relax. Immediately after death, the muscles become limp because there is no signal from the brain instructing the muscles to contract. The muscles still have energy reserves that can be used, so the muscles remain relaxed. The eyelids lose their tension, the pupils dilate, the jaw might fall open, and the body's joints and limbs are flexible. With the loss of tension in the muscles, the skin will sag, which can cause prominent joints and bones in the body, such as the jaw or hips, to become more pronounced. As muscles relax, so too does the sphincter, and urine and feces will pass from the bladder and bowels. Within minutes of the heart stopping, a process called pallor mortis causes the body to grow pale, as blood drains from the smaller veins in the skin. At the same time, the body begins to cool from its normal temperature, 37 degrees Celsius, until reaching the ambient temperature around it, in a process known as algor mortis. This decrease in body temperature occurs at a rate of approximately 1.5 degrees per hour. The expected decrease in body temperature during algor mortis can help forensic scientists approximate the time of death, assuming the body hasn't completely cooled or been exposed to extreme environmental temperatures. Within 2 hours of death, a process called livor mortis takes place. This is the process of the blood pooling in the body due to gravity. If the body remains undisturbed long enough, the parts of the body nearest to the ground can develop a reddish-purple discoloration resembling a bruise from the accumulating blood. Approximately 3 hours after death, the body's ATP energy reserves keeping the muscles relaxed are depleted, and with no more respiration or nutritional intake, no more ATP is being produced. This begins the stage known as rigor mortis, where all of the body's muscles contract and stiffen in the position they are in. Although rigor mortis starts affecting the whole body simultaneously, the first muscles affected will be the eyelids, jaw, and neck. This can cause the eyelids and mouth to open. Over the next several hours, rigor mortis will spread from the face and down through the chest, abdomen, arms, and legs until it finally reaches the fingers and toes. Interestingly, the old custom of placing coins on the eyelids of the deceased might have originated from the desire to keep the eyes shut, since rigor mortis affects them first. Maximum muscle stiffness throughout the body occurs after roughly 12 hours due to rigor mortis, although this can be affected by the deceased person's age and physical condition, as well as environmental factors. At this stage, the limbs of the deceased are difficult to move or manipulate. The knees and elbows will be slightly flexed, and fingers or toes can appear unusually crooked. Approximately 12 hours after death and the peak of rigor mortis, the muscles will begin to loosen due to chemical changes within the body's cells, internal tissue decay, and fluid leakage. This process is known as secondary flaccidity, and occurs over a period of 1 to 3 days. During secondary flaccidity, the skin will begin to shrink, creating the illusion that the hair and nails are still growing. Rigor mortis will then fade away in the opposite direction that it set in, starting in the fingers and toes and ending in the face over a period of about 48 hours. Once secondary flaccidity is complete, all of the muscles of the body will be relaxed again. At this point, if left undisturbed, the body will begin to decompose naturally, as it is organic material. We hope this information has served to take some of the mystery out of the physical process of death. It's as natural as any other part of life, and in a somewhat poetic way, it's how we go to ground, as they say.
For those of you who are just tuning in right now, you're listening to A Sound Constitution at CHLY 101.7 FM. We're fourth-year BSN students here to provide you with health-related information and demystify common health misconceptions. We thank you for joining us today, and please be advised that these information are for educational purposes only and does not replace the advice of your healthcare provider.
I am speaking with Vala Favor, who is a retired registered nurse of 25 years. She graduated in 1988 from the registered nursing program at Langara College in Vancouver, BC. Her specialty was initially in emergency nursing, which she practiced for some time in Chilliwack and in Hope, BC. Later, her love for bedside nursing and helping the elderly encouraged her to transition to long-term care and palliative care, where she remained working until her retirement in 2017. Today, we are sharing her insights and experiences working as a nurse in this rewarding area. And just a small disclaimer, she is my mother. I am a third-generation nurse in Canada, and I am very proud to welcome to the show Vala Favor. Hey, Mom, how are you today?
Well, I'm doing well, and thank you for inviting me.
Thank you for being on the radio with me. This is our last episode of the season, and you finally made it on.
I know.
Yeah, you know. Okay. So, can you start by telling me what attracted you to nursing?
From early on, Karla, I recognized I liked helping people. I was very young. I was 5 years old when my neighbor friend and I decided we would become nurses, and we both did. I had two younger brothers. I practiced on them growing up. They were both rambunctious, so I had lots of scrapes and cuts to practice on.
Initially, you did a lot of work with emergency room nursing. What encouraged you to make that leap into palliative care?
Going back in time, I was working at Hope Hospital at the time, and there was a massive province-wide cutback in the medical field. We're going back, I believe it was 1998. The province of BC was revamped into fewer regions, and as a result, there were fewer hospital managers and head nurses, and more responsibility fell down to the RNs. I was working at the time at Hope Hospital. It was a 25-bed hospital. There were 2 RNs on any given shift. And we were responsible for emergencies, maternities, patients, and staff. It got to the point that I personally felt I no longer could provide the care needed for my patients. And that's when I transitioned over. By not having the head nurses and not having the managers, so much more responsibility fell down to the RN that was the acting charge nurse at the time. Mm-hmm. And so, you know what, that's what encouraged me to move on. And I moved on to extended care which also offered palliative care.
When you first started working in palliative, did you feel comfortable supporting people in the dying process, or did you find you needed to learn new skills or enhance your knowledge?
Do you know what? I always felt comfortable, but I also wanted to be able to help them as much as I could. And so I did take courses. I took whatever courses were available. I read literature on palliative care. I wanted to be very comfortable with the palliative protocols that we had. You know, I wanted to understand the medications that we were helping them with in their transition to keep them comfortable. I also talked with the doctors because the doctors had a different perspective than the nurses, and I wanted to understand their perspective. And then I also spoke with my co-workers, nurses, you know, what kind of experiences they were going through and how they dealt with it. The nurses were the most helpful. The doctors, during my time, we're going back 5 years, there was a hesitancy. Doctors had not reached that pivotal point of MAID. Nowadays, we've got MAID, the medical assistance in dying.
Yeah.
And that, it wasn't well known, and things have changed with that program. In fact, they changed this spring. And so I would like to think that doctors are more versed in that transition of going, you know, from regular life and extended care to the palliative. But in my time, they were hesitant. And we would approach them as nurses and say, you know what, we think this patient is ready to go into the palliative program. And every once in a while, I would encounter where they would say no. And then I would approach them again a week later, or, you know, and it would take time. It took time.
When the doctor made the decision to transition a patient from the acute care with full medical intervention to palliative care, what were some of the deciding factors that they took into account? How did you rationalize that decision when you went to the doctor and said, I think this person is ready for palliative care?
The prognosis. The prognosis was very prominent. Pain management, the quality of life for the patient. And usually, you know, the age of the patients that we were working with, they were older patients, so that, you know, chemo wasn't an alternative for them.
Can you tell me a bit about the nursing protocols that you used to guide your practice when you made decisions for end-of-life nursing care, and what were some of the standard changes that happened?
We had set protocols that we would follow, and one of the first things, usually medications were discontinued. And so only certain medications for pain control and comfort measures were used. And then often, like, you know, we would look at what kind of medications they were taking, and they would have to be changed because pain management was one of the biggest factors that we were dealing with. Things like, you know, toileting a patient, we didn't worry about that anymore. Sometimes we would put a catheter in just so we didn't have to worry, because that transition stage could take sometimes, you know, just a few days for them to pass, or it might take a week, or it might take 2 weeks.
Mm-hmm.
And so for their comfort, sometimes we would put in a catheter if they didn't have it. Oxygen, we would wean them down because we felt that keeping them on oxygen would prolong that process.
Mm-hmm. How did you support family through this process?
Oh, the biggest thing was to listen to them, listen to their concerns, and to be as truthful as I could. The ones that were involved, they were, of course, the ones that were quite concerned for their loved one, okay? Mm-hmm. And usually that was a parent, sometimes a brother or a sister, but usually a parent. So they felt very responsible mm-hmm. to their parent, and they didn't want them to suffer. The doctors, I found, Karla, were not that helpful. They would write the order to say that a patient was now palliative. And for the most part, it fell on the nurse's shoulders to go and talk with the family and say, okay, this is what has happened. This is how we're going to work with your mom or dad. And do you have any questions? And then I would just take it from there. I remember literally taking a chart into the room and to be as truthful as possible, let them ask me whatever questions, and then I would answer from the chart. Mm-hmm. And that would help them. Mm-hmm. The other thing was to provide a quiet, private setting. That was very important. Sometimes, where the patient wasn't private enough. And so we would have a palliative room mm-hmm. and we would move them into there so that they had a private, quiet setting. There was a couple of other things, depending on how long the process would take, the family members would have a hard time leaving.
Yeah.
They felt it was their responsibility, that they had to sit at the bedside and do whatever needed to be done. And so I would have to reassure them and say, look, based on what I'm seeing, your mom or dad is not that close. You can go home. And I make sure, just keep the phone close. I will certainly phone you, because it was very important that they maintained their energy levels. So they had to go home and rest and have a bath and make sure that they were fit. I also encouraged them, if they wanted to bring in music, they could bring in music, to bring in food. We would have a palliative tray so that we would bring in coffee and tea and cookies and crackers and cheese and things like that. So we tried to make them as comfortable as possible. And towards the end, those that wanted to stay in the room, we would quite often bring a jerry chair into the room. And if one or two wanted to stay, that was fine. And they would sleep at the bedside.
What types of questions or concerns did the family bring to you about the dying process?
Sometimes the first question was why. They want to understand why. Isn't there something that we can do? They would question, why can't we just give them antibiotics?
Yeah.
Or why can't we go this path? Why is the doctor leaning towards palliative? And so I would try to explain that as much as possible. Probably, a good example is my mom, your grandma.
Yep.
She could have lived longer.
Mm-hmm.
She had a fall, as you know. She had a fall, probably brought on by some cardiac problems. And when she fell, she absolutely shattered her pelvis. And Mom was so independent. And to be in a setting where, the things of daily living, to be toileted in a sling, not only would she be in pain, but her dignity was lost. I remember coming in there and her gown had shifted, you know, and so I felt so sorry for her. I remember, you know, Mom had fallen. Mom was in the hospital and being cared for. This was probably day 2. And I got a phone call from her specialist. And he said, your mom has made a decision to go through the MAID process, the medical assistance in dying. And, you know, I certainly respected Mom's wishes. She could have lived another year, but it would have been a year of being on bedpans or being toileted in a sling. And that was one of Mom's biggest decisions where she said, I do not want to live like this anymore. And right beside that was pain management. Any type of movement like that would be painful. And within a few days, I remember coming in to visit Mom, and she said, boy, I see the writing on the wall. She said, I needed to use the bedpan. And I've got a clock in here. I ended up being on the bedpan for 20 minutes, even though I had finished. That was so incredibly uncomfortable for Mom. And so that is where I can say I certainly understood Mom's wishes. This was her process, and that was something going back to family. I would remind them, this is their process. This is, you know, the patient's process. And we've got the right to make that decision. So we're here to support, and that was the role of the family to support, you know, and we as nurses were there to support the family.
We're there to advocate on behalf of the patient and support them in their wishes and communicate these wishes to the family. But we're also there for the family to understand the prognosis, to help them to understand the prognosis, and what types of risks, health risks, or symptoms that the patient might live with if they weren't going through the MAID process.
Yes.
So what lessons did you take away from participating in the dying process of your clients, and how did you apply this in your own life?
That life is precious. Enjoy every day. Say the things that you need to say now, because there may come a time when you won't be able to. Enjoy your family. Make time for the little things, you know, dinners, going out for a walk together.
Oh, that's beautiful. Thanks, Mom. Okay, so from your perspective as a nurse, what advice do you have for new nurses who will be helping others in the dying process?
To listen. To listen to their patients. In my time, sometimes I was very chatty, and the palliative process is not the time to be chatty. To be there in a supportive fashion, number one is to listen and non-judgmental, to accept them, you know, and each situation is different. And when you're talking to the family, I used to be very careful not to say, oh, I know what that's like. Well, no, I shouldn't say that. It's very important that they recognize, and I recognize, each situation is unique. And so listening is the biggest factor, and to be there in a supportive fashion.
Thanks, Mom. You did great, Mom. Thank you very much for sharing your experience with us today.
Oh, you're welcome. I hope I helped someone.
You've been listening to an interview I had with my mother, Val Lefevre, a retired RN of 25 years who specialized in emergency, long-term care, and palliative nursing. She was sharing her insights and experiences caring for clients and family at the end of life. Here's our last soundbite for the road, titled Life Lessons from 100-Year-Olds, created in December of 2016 by executive producer Life Hunters, first airing on YouTube. They asked 3 unique and lovely centenarians what their most valuable life lessons were. Let's listen now.
You've got to keep up with the times. So what was good in sort of 80, 90 years ago doesn't work these days.
Well, communicate, speak with your parents and take their advice too, or at least consider it. You don't always have to follow it, but certainly don't throw it out of the window.
I recommend anybody, if they find the right husband, to marry. Not just live together, marry. Be closer and closer. It seems to me as if you are happily married and happily living, that is the finest remedy for all ills, because everything is in perfect harmony.
Time spent on reconnaissance is seldom wasted, and be as independent as you can, but don't be reluctant to ask for help when you think you need it.
Good idea is to behave well to other people, show them respect, and help them as much as you possibly can, and it will be repaid hundredfolds.
My motto for life, there was an old Scottish comedian, Sir Harry Lauder, who used to sing, "Keep right on to the end of the road," and that's my motto.
Keep right on till the end of the road. Keep right on to the end. Though the way be long, let your heart be strong. Keep right on round the bend.
That was Life Lessons from 100-Year-Olds, created by executive producer Life Hunters and first aired in December 2016. This brings us to the end of episode 7, which also brings us to the end of the 2021 season for A Sound Constitution on CHLY 101.7 FM, VIU's very own campus radio station. If we could sum up our heartfelt wishes for you, our listeners, it would be for everyone listening to live long and happy lives, full of the knowledge they need to make wise decisions about their health. That's it, folks. Thanks for listening, and join us again next year when our new team of student nurses join us to talk about health literacy on A Sound Constitution here on CHLY 101.7 FM.